So this is a fireside chat without the fire, but we did insist on comfy chairs, didn't we, Billy?
Yes, just missing a pipe and a glass of whiskey.
We are, which we'll have that in the bar afterwards, I'm sure. And we have our colleagues on Zoom. Welcome everybody who's joining us electronically. You're very welcome at home. And what we thought we would do in previous sessions, we had a lecture from the speaker and then a little fireside discussion, then questions. But we thought we'd throw it up in the air, didn't we, Billy, tonight? And we would just do a fireside discussion. And we've kind of decided on some topics. And what we thought we would do is have a little discussion and then welcome questions from the audience as we go along to make it more interactive so that all of you are part of this fireside discussion rather than waiting for questions at the end. And feel free to jump in and we will pause and have a look around if anybody has questions. So just from the introduction, I've given people a little taster that you hail from Northern Ireland, but can you just tell me a little bit about your background and where you grew up and what your family dynamics were like as we start off this journey tonight?
Yes, so I grew up in Belfast, and actually whenever I speak to another Irish person, my accent tends to get thicker and thicker and thicker. Yeah. So you need to shout if I become not understandable at any point. Yeah, grew up in Belfast in a big family, so very loving family. Knew that I wasn't special in that family. I was one of many. Got really interested in electronics as a teenager. There was a scheme that was running in Ireland back in the 90s called Project Children, which was the idea was to try and get Catholic and Protestant kids to understand and be friends. So they sent us to America together, and we spent 6 weeks with the family. And there, it really kind of opened my eyes to broader possibilities outside of what I'd seen in Ireland. So went to North Carolina and then to Washington. And I think the other thing that I did was spend most of my time in Radio Shack, which is like an electronic shop. So I was like looking at resistors and transistors and stuff like that. So really developed a love of engineering and electronics back then. My brother actually came and studied a master's at Cambridge, so at Trinity Hall. So when I visited when I was 14, I was like, this place is amazing. I want to come here. And my brother said, it's a little bit hard to get in. I wouldn't necessarily think you'll be able to do it. But I remember standing under the statue of Isaac Newton down in Trinity Chapel, thinking I want to come here. And then a few years later, I did. So I had a very, very happy time growing up and then coming and studying at Trinity Hall back in 1997. We actually had our 25th reunion a few weeks ago. So
nice.
Yeah.
But you had a little blip towards the end of your degree, you were telling me. Are you happy to share that with all the rest of the audience here about how you ended up in the lab first?
Absolutely. I think there's a kind of lesson in entrepreneurship that often unexpected things set you on a path that you didn't anticipate. So at the end of my engineering degree, I got a letter from the bursar saying, if you don't pay your bill, we're not going to let you graduate. And most of my kind of grant and student loan had been already committed to the bar in Trinity Hall through the year. So my director of studies at the time said, I tell you what, come spend 3 months working for me at the engineering department. So he had a research post open, and it was looking at microchips in telecoms. So he said, I'll speak to the bursar and you can use some of that money to pay off your room bill. And that actually was what led to me meeting my other co-founders up at the engineering department and really getting stuck into this particular research field of chemical sensing and silicon devices for chemical sensing. So it was
serendipity.
Yeah, absolutely. I think it's a pattern that shows up quite a lot for me, and I think for all of us, sliding door type moments, unexpected things happen. You can't quite write a plan for that, but often if the hook is cast, then hopefully a fish will come along eventually.
Yeah, so armed with your engineering degree and your lucky break, but you got the engineering degree.
Yeah.
You then basically focus more on research. Is that what happened?
Yes,
So
that's
did you
that's
do
right.
a PhD then?
So I actually went straight into, it was a postdoc position,
Mhm.
so it was a research associate position. So it was meant to be originally for 3 months, and me and my director of studies, who was running that project, we got on very well, and I was able to kind of crack the problem that he was trying to solve in that first 3 months. So he said, "Why don't you stay on?"
Oh, I see.
So
So did this lead to the development of the first sensor that you built, the famous technology?
Almost. So the project that we were working on was trying to develop silicon devices to do things like move optic fibers around. So in the kind of late 90s, early 2000s, there was a massive telecoms boom. And the project that we were working on, it had industrial partners as well as different academic groups. And I started that research job literally just as the telecoms bust was happening. So we went to speak to some of the industrial partners, and they're like, "This is a really interesting research project, but our company probably won't be around in a few weeks' time." And that was indeed the case. So it meant that actually the original research focus was able to shift, and we started to look much more at chemical sensor technology. So again, it was one of those. Yeah, serendipity is probably not the right word for what happened in the telecom sector. Yeah, so it was a pivot, but we were able to apply a lot of what we'd understood about how you manufacture these silicon devices to try and think about what are the other problems that we could try and solve using this technique.
And you were using those for security and environmental waste? Toxicity, etc.
Yeah, exactly. So the core technology is a bit like a electronic nose on a silicon chip. So if you think of other techniques like mass spectrometers, they're usually massive, cost a lot of money. So what we were able to do is say, okay, you can take that approach of separating out different chemicals, but by applying these silicon manufacturing techniques, shrink it down to the size of the chip. So I've got one here. Sadly, for everyone in the audience, silicon chips are excruciatingly dull to look at. A small little bit of silicon in there. And what kind of makes it special is the same hardware you can use and just change the software to look at different chemicals. So we actually, way back then, we were thinking about, okay, there's applications in security. So this is looking at toxic gases, in food safety, industrial process control, so contamination, food stuff, wastewater, and further down the line, also thinking about diagnostic applications as well. But we knew that would take time, so that's why we.
But you were still thinking about medical diagnostic applications at this early stage.
Yeah, exactly. So I was thinking it's a platform technology, it can be used in different areas, but how do we navigate a path where we're able to raise initial financing, get the technology mature to the point where we can prove it works, etc.
And that's a journey that a lot of entrepreneurs undertake. What they start off, and you'll find this in your own businesses, might have no resemblance to your successful endpoint, but you almost have to undergo this process, don't you, to mature to the point of spotting the real opportunity, which you did in 2016, was it? Yeah,
so the initial spin out focused on security and industrial applications. We were able to win quite a lot of funding from security agencies, industrial clients. So it allowed us to get the technology and the products. So we then started to look more at these medical applications. And the way in which we were doing it was, has anyone ever heard of cancer sniffing dogs? You kind of see it, it pops into the newspapers quite frequently, actually. So, the raging skeptic in me was like, oh, yeah. People have been trying this for, 40 years, and there's no tests on the market. And the approach that we took is say, okay, we have this technology. Let's work with academic groups who were running clinical studies to try and find chemical markers of disease in breath and in urine samples as well. So actually, for us, that was quite a low risk way to try and explore this entire new application, because we were able to sell instrumentation to some of these research customers, but they understood the problem that they're trying to solve. They were recruiting patient samples, running those samples, and then ultimately publishing the importance of that. And I think once that started to happen, we said, okay, it looks like there's, a gem of, a new idea aligned with this need for early detection and, precision medicine.
And you approach this very collaboratively. So this is how you amassed a lot of an academic body of research, because you were co-authors on papers, presumably, and facilitating and enabling their research.
Yes, absolutely. So I think what we tried to do is say, and I think it's generally true, knowing the thing that you're good at and the bit that you're not good at that requires partnership is very important. So I think we were able to draw a ring to say, okay, we are good at capturing and analyzing chemicals that can be applied in different applications. But in terms of really trying to surface, well, do you need a better diagnostic test than disease A or disease B? A lot of that was initiated by our academic partners. Yes, absolutely. So I think working with them was kind of key in that early initial phase, but also, what we do today as well.
There's a lot of cross-fertilization of ideas, and you actually gained a lot of knowledge that then you can use in the next step. You've become a bit of a chemist, a bit of a doctor, a bit of everybody, haven't you? I'd say along this journey.
Yes, yeah. So coming from engineering backgrounds, like I did not and still do not know a lot about biology. And actually what we've had to do, again, is, build a team that's able to piece together those gaps. And I remember actually the very first time we were thinking about running a cancer clinical trial, I went down to see REK in London and said, well, we have this device. We know literally nothing about running clinical trials. Who should we go speak to? And they said, oh, you should go speak to, Bruce Ponder and Robert Rinstall here in Cambridge. And we did. And again, that was, very much they saw that, okay, here's a technology that could be applied in the early detection problem. And, for us, we were able to navigate this whole new field of how do you get set up and run clinical trials? How do you understand the biology of why these chemicals are being produced, et cetera, et cetera.
Complex problems. How many people in the audience are engineers, just to show hands, or do we have any engineers here? And chemists? Biologists? Okay, so we've got quite a few entrepreneurs. Everybody's an entrepreneur. Everybody. Excellent. So, and then in 2016, you spun off your business because you had realized there's enough there to actually go after the diagnostics, but you had another reason driving that with your wife having been diagnosed.
Yeah, that's right. So we had this the technology, some of the clinical trial results coming out, and we thought, okay, it is a very different business, so the funding requirement is totally different. To run clinical trials is eye-wateringly expensive, and the path to get to commercially deployed products is long, and there's lots of risks along the way. There's no guarantee of success in the clinical trials, so that's why we thought, okay, this should be a separate entity. But back in, it was 2012, originally, my wife was diagnosed with colorectal cancer. And it was stage 4 cancer.
Which is bad for any non-medical people here.
Yeah, so it's like about 5% survival chance. And the thing to me that was, and a lot of people know this, but I didn't know it at the time, was how much of a difference early detection makes. So I remember she was diagnosed on the Friday. I still didn't quite understand what was going on. And over the weekend, I was looking at the stats and I was like, she's got a 5% survival chance because it was picked up late. If it had been picked up early, survival chance is 95%.
Was this a light bulb moment, or there was so many emotions? I'm sure it's been devastating for you, that hard to process.
Yeah, like I think, on the one hand, we were, how could this have happened? But equally, we kind of understood that it's not easy to pick up cancer early. She was 34 at the time, so she wasn't a particularly high risk. So she wouldn't have been screened. There's not really a lot of tests that you would necessarily use there, and quite often you think, oh, it's more likely to be IBS. So I think
misdiagnosed, maybe.
Well, I think it's basically a hard problem. So I don't think it's one where you could say, oh, this didn't work, that didn't work. But the facts are we know early detection will save lives. And we know the more tools that we have that can pick up cancer sooner if you're at risk or symptomatic, then we need to do that. Because I think the other thing that me and my wife Kate observed at the time, so the treatment that she was going on, a lot of it was just about extending life. So a lot of the therapeutic interventions at that point can extend life, but they can't cure. So I think that was definitely a light bulb moment for me. But what we then saw is this much broader community, particularly in Cambridge actually, and CRUK, where their goal is to try and get to 3 out of 4 people diagnosed with cancer survive. And one of the biggest opportunities that we have is to pick up cancer sooner when it can't be treated.
Yeah, I think that, and then that was the foundation of the mission for your company, to save more lives, presumably from the cancer detection earlier. Because those stats, when you look on your website, 1 in 10 people who are diagnosed late will survive, whereas 5 out of 10 for lung cancer would survive, and even better for colon cancer.
Exactly. And if you look at the moment, something like lung cancer, so in the UK, that early stage 1 cancer, you only have about 14.5% of people who are picked up at that early treatable stage, because often there's not symptoms, so it is difficult to diagnose. So I think that was a real pivotal moment. And I think before the work that I'd been doing in the company before, I found intellectually very stimulating. So working on hard technical problems, trying to make ions go through silicon devices and stuff like that was intellectually challenging. But I think we saw the opportunity to say, okay, well, can we apply this in what we think is an important problem in society?
To make a difference to people's lives. Purpose, you found purpose.
Exactly. And I think what we find within the company, I'm sure a lot of people in the room as well, they would have had a similar type of experience in their family, be it extended family or whatever. So I think when we thought about what is it that Owlstone Medical is trying to do, it was to try and save 100,000 lives by picking up diseases such as cancer sooner when it can be treated. And it's a kind of easy to frame statement, but behind it there's a lot of difficult technical scientific problems that need to be solved. But it's a kind of collective journey the team and I have, because it is such a common story that people were diagnosed too late.
Did that translate to being easier to raise funds? Presumably most of the 150 million was raised after you pivoted.
Yes.
And you went to what percentage?
Pretty much all of it. So
Really?
Before that, we had raised it's about $35 million prior to
So
that.
that's a massive amount of money for the electronics business.
For the security industrial applications. So most of it was after that. It's interesting because our chairman of our boards, we had a discussion one time about early detection. He was saying he sat in a room with investors one time saying, what's the one problem we need to crack? And everyone's like, early detection. And it's like, what is one of the hardest things to fund as an investor? And everyone said early detection. Because again, you have absolutely definitively, objectively, a very long timeline, a very large capital need, because you need to run these very large clinical studies, and a lot of binary risk along the way. So each clinical trial that you could do has some significant probability of failure. So it was actually quite difficult initially, because we knew the problem that we want to try and solve, but then it's like, how do we bring along investors to support that? I think a few different things happened. So one was there became a broader awareness of this, not just the scale of the problem, but the scale of the opportunity. So the company that can crack this problem, basically has a very large amount of people that benefit from the test. There's commercial opportunity. Exactly. 1 to 2 people will get cancer. So we saw companies being funded quite significantly. So you immediately are able to say, okay, well, here's the space that we're operating in. Here's some of the other companies getting funded at those levels. And then I think the other thing that we did was think about our business model as well. So there's this, destination, which is hard, risky, quite far away. But we also started to look with the technology to say, okay, well, can we sell to academic researchers, pharmaceutical customers as well, which generates a revenue stream into the business sooner rather than later.
Return investment. But before we go into that, one of the things entrepreneurs really struggle with is getting their first Series A round, even a seed round.
Yep.
Now, you diminished your amazing achievement of 35 million, might I say, compared to 150 billion. Yes, it's not less, but how did you learn about articulation? Was it the articulation problem? Was it actually the timing of the problem? Was it your experience by the time you came to your pivot? How was it that you were able to leverage so much funding? Was it luck? Was it experience? Was it all of the above?
Well, I think it's a little bit of everything, actually. Yeah. So there is there's many failed pitches. I think the very first pitch that we ever did to an investor, it was beyond the car crash. So the three of us walked out of the room and said, we cannot let that happen again. It was like, it was catastrophically bad. And we'd actually been to pitch training. So, one of the great things about Cambridge is there's so much support for people wanting to, start businesses. And, I will do everything I can to help all you here as well that are interested in that. And one of the things that we went to was kind of elevator pitch training. So that's like, get your idea out in 30 seconds. Mm-hmm. So me and my co-founder.
What is your elevator pitch, by the way? Put you on the spot.
Save 100,000 lives with breathalyzer for disease. So there was the three of us. There was me, Irish, Dave, Spanish, Andrew, American, and we were all kind of trying to do the pitch. The guy who was facilitating it didn't even realize we were from the same company until the end. It's like, hang on a second. So we were so far away from it. And he said as well, points at me and says, I can't really understand you because your accent. And then he said, Dave, I really can't understand you. And he points to Andrew and said, and you barely say anything. So because Andrew was quiet. So there was a lot that we had to do. But I think, everyone goes through those experiences and it's like, all right, well, keep plugging away. And
if it's too easy, you don't try hard.
Yeah, and I think I used to make the quip that we heard no so many times. I would half expect to go into Starbucks, ask for a coffee, and be told no. So it's there's a kind of degree of just keeping on and like learning from those things that don't work and like keeping those cycles quite short. So it's like, all right, we'll test that message. It doesn't work. Or actually
learning.
Yeah.
It's really, has anybody in the audience any questions or found, presumably you have similar feedback from you? Yes. We're just coming to that actually. Good question.
Yeah. So yeah, they would. So actually one of our investors is a big insurer, Aviva, because when you look at who benefits in early detection, the patient obviously does, but your treatment costs are around 10 times lower as well. So payers, insurers, etc., are the economic beneficiaries of that, which is a little bit different because originally, naively we were thinking, okay, if we go and speak to pharma companies, but actually it was focusing more on insurers. Yeah, exactly, and that was exactly the thing that we observed. That actually, if patients are developing later stage disease, a lot of the therapeutics are more expensive. They don't cure, they prolong life. But I think actually there is clearly a huge amount of value in early detection that will accrue to the patient and payers, NHS, etc. I do think some of the bigger pharma companies do see that, and I think they see, well, someone is going to solve this problem, and actually is there a way for them to work to try and solve that problem. So actually I'm quite optimistic that
they're spending a lot of money on digicetics. You might be familiar with that term, where it's behavioral change. For instance,
Yeah.
videos on, leading a patient through a VR experience about smoking, and you go into one room and it's dirty, smelly, and then you end up in a field of daisies, and how wonderful that is, because they know this is coming, and it might take 30, 40, 50, 60 years, but eventually we will be talking more about wellness rather than illness. And I think that's where you're going with all this, really, isn't it?
Yes, absolutely.
But on the road to that, you have been very smart in that your business model is R&D, you've got your pharma partners, you've got your academic institutional partners, and also you've got return for investor hard cash with your commercial entity, which is presumably this. Do you want to, this be a good time to show?
Yeah, so the core,
it's all about?
So one of the things that we, again, thought naively at the start was, when we have the sensor technology, you put one of those in every GP's office, but actually a GP may only see 10 lung cancer cases every year. So the economics don't really work out. You can't sell a device there. So we partitioned the sample collection, so capturing a breath sample, separated that from the analysis. And what we know is that you need to pick up the cancer sooner, but it doesn't matter if you get a real-time result or if you get the result after a day or 2 days or so.
Yeah.
So that allowed us to, and it took like a year to figure that out.
Who helped you figure that out? Talking to your user base?
Yeah.
Okay,
So it
because I think
was,
that's really a very important message for the entrepreneurs here.
yeah, we spoke a lot to clinicians and insurers
Right.
as well. And, clinicians like, well, I get the appeal of early detection and a breast sample non-invasive, but operationally, they said, if I can collect a sample similar to how you would collect I know that guy, sneaking out the back, similar to collecting blood samples sent to the lab for analysis, if you could do that with breath, that would be a better way to do it. So that's what we were able to do with this device. So essentially a patient breathes into that.
Let's demo it.
Yeah. So just breathe in and out, and if I see you going beetroots, then we're joking, you should be able to breathe through. Yeah. So every time you breathe out,
do you need to take for this to work?
So it can be as little as a single breath, but often what we try to do when we're discovering novel biomarkers is capture breath samples for longer periods of time. So objectively, we know there's a lot of chemicals on your breath. So the kind of two big questions of what are they, where do they come from? So some are coming locally from the airways. So if you have inflammation in the airways, you get volatiles being produced, which are metabolites basically. But you also have lots that come from the blood, which makes sense. You exchange oxygen and CO2 between blood and airway. So a lot of the chemicals that you get in breath originate in the blood. So what's really cool about the breath sample is with this device, with each exhalation, we can trap and store the volatiles into the
store. There's a white.
So there's a cartridge that sits there, and the cartridge has a material which is a bit like a sponge.
Okay.
So the chemicals go in, stick to the sponge, and then when you do your next exhalation, you trap those chemicals as well. So it's a way to build up the concentration of your sample.
What's the chemical? Are these volatile organic
So
compounds?
these are volatile organic compounds.
Okay.
So that means that with each exhalation, you're able to add a bit more sample time over time. So if you think about one of the limitations of blood, you're only able to get a finite amount of blood.
And it's invasive as well?
Yes, that's right. So once a minute, you have your entire circulating blood volume around your body, through your lungs. So actually, it's a window into this circulating blood volume where you're looking at the whole volatile metabolome. So that's important because if you're trying to pick up, tiny concentrations of chemicals at the earliest stages of disease such as cancer, you need to have that sensitivity to get enough sample.
What is your sensitivity? I know you've done research on this.
Yeah, so we typically detect on a part so analytical sensitivity. So the tiny amount of chemicals you can get is part per trillion levels.
Yeah.
Which very low levels. In the lung cancer, the goal is to try and get sensitivity above 75% in stage 1 cancer.
Right.
We don't know if we can do that yet. So what we've observed so far, when you look at tissue taken from patients that have lung cancer, the approach that we're taking is a little bit different from just looking at whatever you breathe out. So the approach that we have is called exogenous VOC probes or VOC probes. It's essentially where you put a chemical in the body that targets a unique characteristic of the tumor. So it looks for a specific enzyme that's around the tumor microenvironment, and it chops the probe and releases a reporter molecule like on your breath. It essentially signals the presence of a tumor. So it's a bit like if you think of a PET scan, for instance, where you administer a probe in a PET scan, you have enhanced uptake, and that's what you're able to see when you're imaging. Saying, can you adapt that approach, but rather than put someone in a scanner, you release this signaling molecule.
Is £1,800.
Yeah, exactly.
It's 3 times the annual radiation dose for one test versus 2 little breaths like I've just done here.
Yeah. So
and how much would this cost for breath test?
So the goal is to have $150 per test. Okay. So it's not the device; it's the cost per test. And the great thing we think about this probe approach is it's bring the chemical to where the tumor is. For some of the other techniques, you're looking for small quantities of a biomarker which has been diluted into the entire blood volume, and that's what makes early cancer detection such a hard problem. So we think by adapting this concept of imaging, but bring breath technologies into it, should crack the problem. But we're not there yet. So lung cancer, we've got good data thus far, but again, there's different steps along the way in clinical trials where it may not work as much as we hope.
But what about if you thought about chronic diseases? For example, if you have kidney disease, you have this, we call it uremic breath. If you're diabetic, you might have halitosis, bad breath. So breath does seem to be important, and it probably comes from partly the methane produced in the gut, the microbiome, versus even the lungs. So have you thought about adapting to chronic disease? Because that might be an easier one to crack.
Yes. Yeah. So that kind of ties into your thinking about the overall business model. So I think we're a bit like a pension portfolio, right? Okay. So you have your kind of here and now safe thing, which is our research products and services business that we sell to academic and pharma customers today. So it brings revenue in, but it also means that we can explore other applications funded by customers. So it builds out a pipeline of applications. So we don't need to say, we're going to solve problem X and fund that completely ourselves. On the far side, you have the higher risk studies such as lung cancer. And then in the middle, we have tests that we have on market today in areas such as digestive disease. So, patients that have non-specific symptoms, which are very debilitating, actually. So IBS-like symptoms, very debilitating and impact quality of life, both in work and home.
It's irritable bowel syndrome.
And so the test that we have there is able to say, okay, it looks like you have a particular bacteria in your small intestine, and therefore that can be treated with drugs such as rifaximin.
So how does that work practically? Does the patient go out and purchase one of these themselves now, and then somebody tells them they have that, and then they go to the GP? Because a problem over the years, for example, in bone density screening, American companies show up in a shopping center with a little tool. They give a printout and say, oh, you've got osteoporosis. Of course they don't, it's only a surrogate. And then the patient comes into the GP goes nuts about that American company doing screening and sends them over to secondary care, and there's a glut. So how will you avoid that problem with breath testing?
No, it is like we want to make sure that's not where we end up. So in digestive disease, where our test fits in now, it's after patients have been to the GP and then get referred to a specialist.
Okay.
So the specialist is saying, I will do a breath test. But what is great about the breath test is the rather than the patient having to come into the clinic, and this was particularly important through COVID, you can send a sample collection kit to the home. So it's different from this. We use this more when we're trying to discover biomarkers. So the sample collection in the home looks like a little glass test tube, actually. So the patient drinks a carbohydrate substrate, and then over time you blow into the sample collection tubes, cap that off, and then that comes back to us for analysis. So we can then say you have small intestinal bacterial overgrowth, carbohydrate malabsorption, and that information is going to the doctor that's ordered the test.
But I could see an opportunity in the future for the doctor at home, and really since COVID, there's 6 million people on the waiting list in the NHS, and God knows what there is worldwide. And doctor at home is emerging. You know, I'm still a clinician practicing. Patients are coming in with testing with Strava, with their iPhones, and I think there's an opportunity to take some of the pressure off the health services and cut out the doctor element for some of these conditions. Do you see that?
I wouldn't necessarily say it's cutting the doctor out, but it's making their lives easier in some ways. So something like digestive disease, you know, if you've got a limited amount of time to see a patient, the beauty of breath test and breath technology is it's non-invasive, so you can do it in a home setting. So you're able to combine objective biomarker data along with information that the patient can collect themselves, so symptom diaries, food diaries, etc. So you can collect all that information in a way where the doctor is then able to make a better determination of what's actually going on.
It's not standalone yet, is what you're saying. It needs to be used in conjunction with other therapies.
I think you need to avoid exactly the problem that you outlined of a patient being able to do something and not know what to do with that information. And I do this stuff, like any new test, I'm like, I'm going to do that. But I'm like, well, what does it mean? And so I think you always need to be quite cognizant of, well, you know, putting the patient first place and saying you can have a technology and a test, but ultimately you want to have a particular outcome that's beneficial for them. And I think the opportunity in digestive disease is that, you know, because it's quite difficult to figure out what's actually going on, the patient wants to, you know, find a problem and have the problem fixed, basically. So it's how can you provide all the information that's going to get to that outcome, but, you know, involving doctors as opposed to trying to.
See, what I'm hearing here is that you have been listening to all of your user base and your collaborative partners, because many times companies go off on a limb and that's why they fail. You understand the ecosystem, what the stakeholders want, and you're not working in isolation. I think that's actually really important for entrepreneurs to understand too, don't you?
Yeah, no, I agree. And, you know, again, we've learned that the hard way in terms of we have made products, they don't work or sell. And often that's, you know, because of a failure to properly engage.
Do people in the audience feel that they would embrace breath technology if they have it available, if you were able to diagnose cancer? I think everybody would probably be keen.
How long before we get into everybody's time?
We have discussed that. So the challenge if you put it into a phone is your phone then becomes a medical device. So actually there's a slide I think that we have, maybe it's the one, this one here. So what we're working on at the moment, so these are the kits that we send to patients home in digestive disease. One of the challenges is it only gives you kind of single measurement in time because you've collected samples and sent it back to the lab. So what we're working on at the moment, which we'll aim to release early next year, is a device that can be used in the home that you breathe into it, and it gives you a real-time measure of these compounds of interest, hydrogen and methane, which are compounds of interest for that particular condition. So this allows you to generate longitudinal data over time, which tells you if the treatment is working, etc. And what we've done here is the device talks to the phone. So, you know, Bluetooth to the phone, and you have an app on the phone that allows you to record symptoms as well as food diary, etc. So we're using the phone, but not integrating the device into the phone.
I was thinking more for the sports development people. So, you know, feedback on if they've been exercising, will be exciting certain compounds from food that they've been eating. Muscles are burning.
Yes.
So you move away from being a medical device and
Strava.
And actually there's a few devices already there that can tell you if you are in a fat burning state or burning carbs. The
from a financial gain point, you're selling. So my pickup as an entrepreneur is if I'm selling to businesses, I'm quite happy to take money. If I'm selling to sports people, I'm quite happy to take money. If I'm selling to sick people, I really like it. So from that aspect, to be able to take money from companies, personal entrepreneurs, if you're selling to the sports people, you can get a lot of money from them, because then finance is neutral.
Yeah, no, I hear you saying. I think part of that comes back to, you know, how do you fund different parts of the business through, you know, what can be commercialized today. I hear what you're saying there. The one observation I'll make is that think about it from the types of problems that should be solved. You know, it's not necessarily the patient that's paying, you know, it's the insurance company or the payer that's paying. So we've basically looked at applications that tend to fall more in the consumer wellness type space as, yes, you might be able to get a sports person obsessed with, you know, burning carbs or fat or whatever, but that's taken us away from what we think the company is trying to do, which is, you know, find these very difficult problems that have, you know, a big impact on patients. So obviously early cancer detection, but, you know, in digestive disease, it is, you know, it is the leading cause of workplace absenteeism after COVID. So I think we want to focus on that. And I think because there's one company, again, go back to the, you know, fat burning and stuff like that. No, it's something that we've debated internally, because it's a way to say you could bring revenue in to fund, you know, other, you know, research streams.
This comes back to your strategy and your focus as an entrepreneur, probably why you've been so successful, because you are able to spot the opportunity and think, well, actually, that's not in our strategic vision.
Yeah.
And that's what you're.
Yeah, exactly. So it's saying no to stuff, because with the research products and services, we get a double benefit. So one is the revenue coming into the business, but the second thing is it builds out our pipeline as well. So when you look at how to value the business, you know, a new application coming into the pipeline has the potential to be a lottery ticket type payoff, where something which is, you know, device aimed at, you know, wellness type applications is just about straight revenue generation, but it's not going to have the same revenue potential as something like GI disease or lung cancer, in our opinion. And we've seen companies come up in the breath space saying, I'm going to do breath freshness and, you know, sports wellness and stuff like that. They tend not to have legs, basically, because you'll get that initial early adopter. Yeah, I'm going to buy it. Then it goes in a drawer, you know, after a month, because actually what they're trying to do there is say, am I burning fat? Well, yeah, you can stand on the scale to get that answer. You don't need this intermediate biomarker on breath. So that's why we've kind of examined but said no to things like that.
And you do have a lot of competitors.
Quite interested in knowing how you would position and how did you position it and what was the strategy like? Because when I think about there's of course natural say the communication, early 20s, and they go in for an hour and 6 months from now. And with a vet analyzer, how does that fit in the paradigm, and how do you it's on board to actually draw that?
Yeah, so I think it's working within the guidelines. So again, back to the point of, you know, you need to work within the community and different stakeholders. So in lung cancer, for instance, where our main trials are focused, we would aim to try and develop tests or launch a test in that at-risk population. So the current guidelines are over the age of 55 with a 20-year smoking history. And two of the observations that we make is that the test that you have there, so a low-dose CT, which is an imaging-based test, the uptake for it is very low in the US. So if everyone is eligible, only about 4% of people actually go for the screening. So we think breath can potentially solve the uptake problem there. But also people who fall outside of the screening guidelines get lung cancer as well. So I think ultimately who's eligible for screening will change over time as we better understand risk factors beyond age and smoking history.
Yeah. We marketing that as a product to different stakeholders, peers in the US and peers, like how is that being actually, what's your strategy where could you put it in for people who are at risk or not at risk?
Well, so the lung cancer test is still a clinical trials phase. So we work with KOLs, key opinion leaders in the clinical trial. So we're not at the point where we're marketing that particular test, but it would be aimed at the at-risk screening population. And the second place where lung cancer test can be deployed is patients who have had a CT scan where there's a suspicious finding, so an indeterminate nodule. Often the approach is taken there is just image again after 3 or 6 months. So can you have a breath test to augment that to say, is this actually likely to be a cancer or benign nodule? So that's the kind of two positionings. But actually it's like, it takes a long time to put together the target product profile to define exactly where it is that you're targeting. And that then informs the clinical trial. Because quite often you can run a long clinical trial, but if you haven't generated the evidence that you need to sell for that particular indication, that's a problem.
Good question, Bill. I think we've went down there. Yeah.
Yes, so thank you. My question was regarding patients with colostomy bags.
Yeah.
Gases do collect
Yeah.
there as well.
Yeah.
Analyzing gases much.
Yes. Yes. Actually, all the original VUC work that we did was in urine and fecal samples, because breath was a much harder problem to crack because of you need to standardize how you collect the sample. And so short answer is we do think it's possible. Some of the challenges we identified came down to things like the sample collection and the sample shipping. So the volatiles, by their very nature, are volatile, so they kind of escape into the environment. So when we're looking at some of those other sample types, it's quite difficult to solve the sample collection stabilization problem, whereas we were able to address that on breath. I think because you're right that the volatiles are being produced locally there, but they do diffuse into the blood and they do come out into the airways as well. So it's basically trying to think about what is likely to be most acceptable, but proving that you have the performance, sensitivity, and specificity for that. But yeah, we do talk about that, and again, it comes back to the focus question. So we originally were more of a VUC type company, and it's like, should we be VUC or should we be breath as a subset of VUC? And we came down on that because it would have been too hard to solve those other
We have
problems.
one more question here.
Thanks, amazing talk. Good question. How would you estimate the current risk of under or overdiagnosis using this technology? And second part of the question, have you looked at combining the data with imaging or sound?
No, absolutely. We see it as multimodal. So if you look at lung cancer, so where uptake is quite low in those at-risk populations, can you get improved uptake because you can go into the community to collect samples? But once you have a positive test, you would refer someone for a CT scan. So it needs to be part of that continuum of multimodal approach. What was the first part of the question? Sorry.
Well, touching on those,
yeah, it's a very live debate in early cancer detection and screening. So if you look at the at-risk population lung cancer, so maybe you'd have about 1.4% of people who would test positive in that at-risk population. So it becomes very important to make sure that you have very high specificity so you don't have a lot of false positives. And also what you see with some of the other approaches, things like liquid biopsy, where you're looking at biomarkers in blood, there's a reasonable fraction of people who are testing positive, but don't actually have cancer. And that's a big problem in imaging. So if you look at low-dose CT, so I think in the US trial, the pivotal trial that was run, of those that tested positive, something like 38-39% is actually false positives. So, you need to look at it in the overall health economic framework of, are you actually doing good and saving money? But it's
a long road, between technology development, then disrupting how people think about their health and wellness. And eventually, as we were saying, it's a bit like institution economics. It's a 50-year cycle that people will be so well that they'll probably be doing this at home. Could I just close though, because I want to ask you one final question. I mean, clearly you're an incredibly successful entrepreneur. You know your game. You've given amazing tips on how to kind of find your user base and deal with stakeholders. But how do you stay sane when you company with 200 employees, 100 patents, 100 papers, and all of this amazing innovation? What do you do to stay sane yourself and preserve your own wellness?
Well, in my 20s, it was going down to the pub and smoking cigarettes. Yeah. But then after my kids were born, I was like, okay, that's probably not a sustainable way to de-stress. So I do a lot of running, which was very welcome during COVID times, when I could step out the front door.
Is this like, do you have marathons or half marathons or?
So I started doing ultra marathons. Yeah, so I did an ultra marathon back in the summer, which was partly to raise money. So my wife Kate, she wrote an amazing book called Late Fragments, and she helped raise a lot of money for different charities. So Deborah James, who died in the summer, colorectal cancer, so I did a run to try and raise money for CREK and the Deborah James fund. But it was the week in Cambridge when it was 40 degrees, I'm sure. So, and it was what we were doing. So my wife Kate, we have on her birthday every year in July something called the Catestival. So all her friends and family, we all come up and have a big party, remember, and have fun on her birthday. And when we went to do that on Saturday, I was like, it's going to be very hot on Saturday. So I ended up getting up at 3:30 in the morning on the Friday and doing, it all around Cambridge, but basically trying to find wherever there was shade in Cambridge on the 100K run. So
that's grit and determination, which is what you're translating into your company. I think we've timed out. We could probably stay talking here all night, but we're very grateful to you. Thank you so much. I wonder, what do you think Kate would say if she was listening here? She's probably listening. What do you think she'd say about all of that you've achieved?
Would she say? She'd probably tell me to empty the dishwasher or something.
You better get used to the bar and get your drink so you can empty the dishwasher. Thank you so much, Billy. I mean, I hope you've all been as inspired as I have. I mean, what a successful entrepreneur, a lovely person, a great father, entrepreneur, chemist, engineer. The list is endless, and recipient of an award from presumably the Queen before she died, your MBE.
Prince Charles.
Prince Charles. Yeah. Perfect, the King. So thank you so much, and thank you everybody for coming. And please, I don't know if there's any more drink left, but please keep coming to these events because they're really, really helpful if you're starting out or even if you're in the middle of your own venture. Thank you.
I was just going to say one.
Billy joining us has joined us.
Yes.
An entrepreneur event.
Yes.
So he will be around. We'll make sure he's around. You'll be able to talk to him hopefully often here at King's. So welcome to King's as well.
Yeah, no, that's exactly what I was going to say. Please do. I will be around, and I love to talk to anyone about business ideas, and I will make myself available.
This is my last question. You made a quite impressive journey from being an engineer to being extremely successful entrepreneur. If you can share with us the key lesson that you learned on this journey, if it's possible?
Yeah, so I think there's a lot of very kind words. A lot of it goes to our team. Yeah. So again, I see my job to get money and assemble the best possible people to solve these problems. But kind of below we've raised money, we've got lots of partners and stuff like that. There is a day-to-day difficulty of stuff doesn't work. It's really hard. There's a new thing we need to contend with. And it is literally being able to take it on the chin day after day and say, but it's worth it. So I actually think that is, we've been doing this for a long time, and there's been plenty of times through our kind of company history where we thought there was insurmountable problems. So, that would be the one thing that I think is an absolute prerequisite, is the ability to keep going.
Keep on going. And
But
it's-
then sometimes, like the whole feel fast mantra, I don't know how to reconcile those two things. Like James Dyson, amazingly, vacuum cleaners, 5,146 prototypes he put together before he had a commercial success there. So you need to find your own line between grit, determination, and feeling fast.
And I think
Really, cheers, thanks.
I hope you were photogenic. You'll be in the box.